really back in 2012, Homeless Link and St Mungo's, they did a big report that was saying up to 70% of patients who were homeless were being discharged to the street. There was, at this time, intermediate care was seen very much as an elderly care model and not something, that people who were homeless were eligible for. And in response to this, we had a government programme that launched in 2015, and this was £10 million for hospital discharge schemes across England. And with this money, 52 schemes were set up. And the first big piece of research we did around this was with the National Institute for Health Research. It was a £1 million. It was a really big evaluation, and it was an effectiveness and cost effectiveness study. We looked at 3,800 people who'd been through specialist care. It was linked to hospital episode statistics data, and that was like Andrew Haywood at UCL. It was a really big, robust study. And really, this showed that having a specialist homeless hospital discharge team with step down was effective and cost effective when compared to standard care. And we could show things like it reduced people who'd been through the sites with a specialist scheme were able to sort of reduce A&E attendance by 18%. And it showed a lot of those guidelines. On the back of that, NICE at this time were developing a new integrated care guideline for people who were homeless. And this actually took in that big NHR research. And there's a recommendation in that specialist intermediate care, that's intermediate care designed specifically for patients who are homeless, it's value for money. But they also noticed it was rare because, of course, what happened in that first tranche of 10 million funding was that once the money ran out, all those schemes tended to evaporate. They disappeared. So the Out of Hospital Care Models programme came along to try and implement this NICE guideline. At this same time, we also had COVID, and the hospital discharge guidance was completely changed. And in that guidance, again, this research was recommended, and it was basically saying to commissioners, you should be commissioning specialist out of hospital care for people who are homeless. Then in terms of the finding, I'm jumping to the findings of the evaluation. At the end of the programme, the people who went through the Out of Hospital Care Models programme, discharge to the street was down to about 5%. And, it was a big success, so from 70 to 5%. We got a new intermediate care framework published. This was saying this should be a therapy-led process. But again, it's flagging the importance of including housing and homeless. Then what we're seeing again, unfortunately, is an exact repeat of the first homeless hospital discharge fund, is that once the money ran out, the projects all started to scale back up. And now we're at the point where we're starting to see again media reports that discharge to the street is increasing. And in a sense, what this evaluation is looking at, it's specifically, can you go to the next slide, Vicky, please? It's what's called an implementation evaluation. So in this work, we're not piloting out of hospital care. We're not looking, is it effective and cost effective? We're looking at implementation. Specifically, what were the challenges of mobilising these services? And most important of all, what are the barriers to sustainability? Why do we keep seeing this lighthouse effect where things scale up only to scale back down again? So really, the overall aims of this evaluation were to roll out models of out of hospital care that could be sustainably financed and would incentivise collaboration. So what is the most effective way of implementing out of hospital care? How are these models being integrated into the new hospital discharge arrangements? And I'll explain what D2A is in a moment. And what are the challenges that now remain to systems and service delivery that require changes outside of the direct control of the organisations in the locality, i.e. what do we need from a national policy perspective. And the final part was really just to test any new innovation that wasn't included in the first effective and cost effectiveness study. Okay, I'll go to the next slide, please, Vicky. So really, I just thought it's helpful to begin by saying what is discharge to assess and what was actually commissioned with the 16 million. When COVID came out, the whole hospital discharge guidance was completely refreshed and changed, and they introduced a policy called discharge to assess. And this was the idea that as soon as somebody was clinically optimised, they would move out of hospital and all the assessments and follow-up care would take place in the community. They introduced a series of pathways, and really the idea behind these was that a lot of older people, when they were coming out of hospital, services were quite risk averse, and they were putting people in very expensive care homes when what would have been ideal in terms of promoting independence was re-ablement and care and support for people in their own homes. And this pathway 1, 2 and 3 was absolutely key to discharge to assess. And the idea was that they introduced discharge hubs in the hospital, specialist nurses, homeless teams, housing, working in the hospitals. But the idea was then that they would have a menu of services so that people could leave hospital as quickly as possible. And one of the key things about the out of hospital care models programme was the idea that homelessness shouldn't be seen as a separate pathway over there, that this should all be integrated. So as I say, the out of hospital care, the 16 million of funding really did boost these services. So in hospitals, we saw a massive increase in the number of homeless teams. So that's specialist nurses, people from housing options, all working alongside discharge coordinators to find patients who are homeless on the wards and then to bring them out quickly into a range of services. So the sort of things that were commissioned was the Red Cross in London introduced a settle-in service. And this was where people in London, a lot of people were coming into hotels, and these Red Cross workers would accompany people as they left hospital. They'd make sure they were settled in, and they'd do quite a bit of work then to sort of make sure after a stay in the hotel, they could find follow-on housing. In Cornwall, they introduced a stay-at-home scheme, and this was actually a block contract of these were carers who were delivering personal care, but they were trained specifically in working with people with drug and alcohol problems, and they were like a specialist domiciliary care provider. In Oxfordshire, we saw a very successful model, which was a number of houses. These were home first, so they were homely environments. They were not institutions. And then on site for part of the day were then workers who helped people sort of register with the GP, establish benefits and get people sorted. The other big hospital model there again was in London, and the Mildmay started to offer 24-hour nursing care for people with higher levels of need. And then the other scheme, interesting new scheme in London, was a team of nurses, OTs and workers, and these would support people right across the system, and especially where people were going into a care home, then they would go into the care home and they would support the people in the care home to deliver care. They were used to working with older people, and before they would be very reluctant to let in anybody who was homeless or with a drug and alcohol problem, because they didn't know how to work in trauma-informed ways. So really the programme, it really did. It had a massive boost of it put in place lots of services under D2A to help people come out of hospital. In actually implementing and moving to this integrated way of working, the idea of pathway 1, 2, 3 and 4, not 1, 2 and 3 was very confusing, because we had homeless pathways, we had lots of pathways. Where was the homeless pathway? And in a lot of sites at first, all patients who were homeless were discharged on pathway naught. And it was quite a thing to say, no, their needs needed to be assessed, and they needed to, exactly the same as older people, to go in pathway 1, 2 and 3. Again, a big thing of the programme was challenging discharge to the street and really boosting it and making adult safe, strengthening adult safeguarding. I mean, very often, the standard practice before out of hospital care programme was just to give somebody a sticky note and say, go to the council. And really what this overshadowed was just the level of need. People who are homeless in hospital are at extreme risk of death. Their needs are kind of very high. In an audit that was carried out as part of the out of hospital care programme, only 1 person out of 100 had just a housing need, and the rest needed to go through the different pathways. Okay, next slide, please. Okay. What was very interesting was that with the money, areas tended to develop one scheme or another, and very few actually managed to put something under each pathway. And Cornwall was actually very unusual in that it came up with a really well integrated model. So people were in hospital, they used the funding, they increased the number of patient advisors from 2 to 3. They had settle-in support, so people, if they were going back to a flat or to a hotel, they had the settle-in reablement. They had 3 step-down houses, and one of these, a big issue, was finding houses that could be adapted for people with disabilities. And Cornwall had a real jewel in the crown, a state-of-the-art step-down house. And care homes, no specialist support was commissioned. And again, what helped speed things up through the hospital was things such as trusted assessment. So here in the step down house, the housing workers, they could phone the reablement team and get them to provide care. They didn't have to go through adult social care. So that was like trusted assessment. And at the end of the process, if people, the ideal frame was 6 weeks. And at the end of this, if people still needed some sort of follow-up care, then a Care Act assessment would take place. But ideally, the aim of this was that people would be maximise their outcomes, that they might not need an assessment. Okay, next slide, Vicky. I'm not going to say for time a lot about the methodology of the evaluation, but it included a kind of a qualitative strand. But one of the interesting things we did was we supported the Department of Health to embed an audit framework. And this was basically that when people came into step down, they'd do a baseline measure of people's, mental health, physical health. And when they left, we did a follow-up to see how needs had changed. Again, some sites were able to link to their hospital episode statistics, so we could look at things like reductions in A&E admissions. We looked at service delivery costs, and each month, each project, each test site would report to the Department of Health. So I'll just go to the next slide, Vicky. I'm just ploughing through. So what we tried to do was, for each of the 17 test sites, we would try and put together for them this kind of dashboard. And the idea, this was a bit of action research, because we were mindful of how the first programme, the sites had just evaporated, and we wanted to make sure that the test sites had the best possible information to make the case to their commissioners. And this was a test site for Oxfordshire, which was one of the outstanding performers across the programme. So they had a very short length of stay, 29 days. We could show decrease in A&E visits, decrease in emergency admissions. I think only 1 person slept rough after being in step down. 100% of people treated with dignity and respect, and 61% had an improved quality of life, which, considering the level of the need, was very good. We could also show costs of the service and savings. So if I just move on to the next slide. What we then did was we then collated all these individual dashboards to try and produce a national picture. So this is that the sites could then look at their performance against the performance across all the test sites. Unfortunately, a lot of the sites really struggled to do the data collection. And I think we didn't, of the 17 sites, I think only about 9 had robust enough data. And that was a real problem. And going forward, they were the sites that then started to struggle to make a case to commissioners. So things like length of stay, again, Oxford was 29 days, but nationally, it was 87 days. So what was Oxford doing that it was performing so well? And that was like the kind of things we were looking at. Again, cost per user, 12,000, but Oxford were delivering the service for 3,000. And so this was the rate, a really good way of like understanding implementation. I'll just move on to the next slide, Vicky, please, conscious of time. So what were the facilitators of successful mobilisation? I've picked on Oxford, but other sites were similar to that. And really underpinning was ambitious planning and visionary leadership. And when I say that, what we saw in some sites was a lot of fatigue about, not another pot of short-term funding. And some sites really just, they used the funding to boost their rough sleeping team for a time, but they didn't really do a hospital programme. Sites like Cornwall and Oxford, that money was seen as a godsend. They wanted to do out of hospital care, and there was real visionary planning. Again, adopting a skilled test site manager was key. In some areas, the test site managers just saw their role as contract management. They sort of filled in the forms for the Department of Health, but they didn't really do anything else. In places like Oxford and Cornwall, we saw what was called like integration mechanics. So the person, if the workers were struggling with an issue, then the managers would come along and they would escalate things to a more senior level to try and address the issues. And this was all interlinked, because where there was no single system coordination and integration mechanics, workers, they became very burnt out, fighting every day. Discharge hubs in some areas were called bear pits, and without the managers backing them up, quite a few of the staff left. So just to go to the next slide, Vicky, please. So again, what were the barriers to successful mobilisation? Well, a big finding of this was, injecting large amounts of short-term funding into the system is not really a good use of money. At the end of the first year, quite a lot of the projects hadn't even started, and this was problems with things like recruitment and retention. They couldn't recruit people quick enough. In London, all the funding came out at the same time. Everybody wanted an inclusion health nurse in the hospitals, but there wasn't a pool of workers. And the programme started out as 1 year, but it had to actually extend to 2 in order to allow the sites to spend the money. So that was a real problem. Again, right across the piece, increasing capacity in mainstream health and social services. People were getting stuck in step down because of the lack of housing and the lack of move on. Cornwall started off with the service, when it originally started, was a 6-week service, but then they started to see issues around, after COVID, people moved out of the city and all the housing went. So it went from a 6 weeks to a 6-month service. And in a sense, these issues of what was important there was not beating areas on the stick. They'd got all the patient flow measures in place, but still there was problems, and these were requiring out the changes at a national level. Again, Oxford and sites were very good at getting people through the step down, whereas in other areas, some, they were trying to do an out of hospital, they were just rebadging an existing service, and they weren't like moving people through. They were keeping hold of people for 2 years like it was an ordinary service. So things like length of stay which was often in London, there was like a reluctance to invest in those services because people were scared of silting up. But silting up was a complex issue. Okay, next slide, Vicky. You're finished. So in terms of sustainability, what I mentioned at the beginning was that, like the first programme, once the programme ended, we started to see the problem of rolling back, sites really struggling to get continuation funding. And really what this was reflecting was no matter what evidence the services had, there was basically no scope for new service developments in the baseline budgets of the intermediate care boards. And it was they were just so tight. Again, the Better Care Fund was the main funder of out of hospital care. And in the sort of 21-22 plan for the Better Care Fund, they said like some funding for out of hospital care must be ring fenced. But OHID, whose programme was this, the Office for Health Inequalities, there was kind of a bit of a missed opportunity, because they should have said, well, some of that funding also needs to be ring fenced for this new work around health inequalities. But that didn't happen. And the advice the Department of Health was giving was that services should look to a wide range of funding sources. And some were successful, but the main problem was a watering down. So if they got money from the Rough Sleeping Initiative, out of hospital, hospital discharge would no longer be the main focus of that worker. So the worker was still in post, but we saw watering down, fragmentation, and again, decommissioning. And we kept seeing, again, in the Better Care Fund, we'd still not got the message across that the needs of people who are homeless, are very high. The funding was all mainly older people, continued to be the priority. And there was no evidence through the out of hospital care programme that the Better Care Fund was actually tackling inequalities. Okay, final slide. I think I'm finished. Vicky, thank you. So really, as I say, we've come full circle. And the question is, what next? How can we stop this lighthouse effect? And just as we published our findings, we had the Hewitt review was published. And this was just saying exactly, what we had found, that funding, using so-called penny packets of short-term funding doesn't work, because it's like a wasteful of money, because all the effort goes into setting things up only for it to scale back down again. In intermediate care for older people, it's long been argued that there really isn't enough of it. And we found, like modelling, the projects, they were good, they rolled out things, but they did not roll out enough intermediate care. And really where, there is a need to make this work, there's really a need for this, getting some funding in the baseline budgets. Again, shifting upstream, prevention, tackling health inequalities. Again, there needs to be money for that in the baseline budgets on an ongoing basis. And finally, we still need to challenge the view that specialist intermediate care is a nice to have. And in the current climate, again, data, we did all this work to establish this audit. And then as the programme evaluation ended, that was not kept going. So we're really back to square one. And if there's, the next out of hospital care programme, we'll have to start from the beginning again. They've not taken forward, because that was a good picture of it, baseline, where we're at and what we needed to do to kind of take things forward. Okay, I'll stop there, because I think that's 25 minutes. Fiona, is it? Thank you.